Good afternoon, and welcome to the Brazilian American Chamber's 9th and final installment in the webinar series called Surviving COVID-19. I am John Welch, Executive Director of the Brazilian American Chamber, and on behalf of the Chamber, we wish you all health and safety in this difficult time. Healthcare systems and workers are the main focus in the defense against COVID-19. In the current pandemic, all healthcare systems have come under intense scrutiny, both in terms of dealing with the disease and with the structure itself. Brazil is no exception. I'm going to turn the the screen over to our new president of the Brazilian American Chamber, Simone Morato from Safra Bank, to welcome our esteemed guest today. Simone?
Thank you, John. Good afternoon, everybody. Thank you all for participating in this important webinar. As newly appointed president of the Chamber in this last March, it's my honor to have my first guest. I know it's the end of the series, but for me, it's the first guest that I personally invited. It's a dear friend, a wonderful physician. He's a doctor in ophthalmology. John will present his bio, but for me, what is important is somebody that has experience in the public sector, has experience in the private sector, understands healthcare, not only in Brazil, but in the world. My dear friend, Claudio Lottenberg. Claudio, welcome, and thank you for joining us and for accepting the invitation from the Chamber.
It is truly our honor. Thank you, Simone. Dr. Claudio Lottenberg was the chairman of the Sociedade Beneficiente Israelita, Brasileira, Albert Einstein. He is also professor of public health at the same hospital, and a member of the São Paulo Academy of Medicine. Just a few more highlights. We could be here all day with this extraordinary bio, but Dr. Lottenberg is the president of Lide, Saúde, vice president of Líderes, Empresariais, and chairman of the board of directors of Instituto, Coalizão, Saúde, Coalizão, Saúde. He was Secretary of Health for the Municipality of São Paulo and remains a member of the State Council for Health Affairs and the Municipal Health Council. He is president of the Superior Health Council of the state of São Paulo and a member of the Council of the Secretariat of Economic Development and Health in São Paulo. He chaired the Brazilian Confederation and was vice president of the World Jewish Congress and currently special advisor to the president of the World Jewish Congress of Latin America. Additionally, he has authored numerous books, including A Saúde Pode Dar Certo, Saúde, and also Citizenship, Technology at the Service of the Patient and Not the Contrary, and that's I guess that's our translation. That book won the Jabuti Award. Dr. Lottenberg holds master's and doctorate degrees from Paulista School of Medicine at the Federal University of São Paulo. Dr. Lottenberg, we are honored to have you here. Before turning the screen over to Dr. Lottenberg, I would ask the attendees to please use the Q&A tab at the bottom of the screen for your questions. You can make them at any time, and we will look to answer them interactively during the discussion. Thank you very much, and thank you for joining. Dr. Lottenberg?
John, thank you so much. Simone, I have to say that I'm deeply honored to be here with you. Besides a good friend, I have you as a reference, as somebody that we, as Brazilians, we are very proud of having you in such a nice condition as a president of this chamber. I'd like to start my presentation with talking something regarding the idea of those that do not understand that healthcare and economics are things completely different. This is not the case. Why? Because according to the GDP, we can have more people in our system that are part of the private system of healthcare in Brazil. More than that, in the movement that you have an increase on the gross domestic product, it means that we're going to have more money coming from taxes. What means that we have a strong correlation according to the production of the country that are going to be oriented in terms of the kind of healthcare that you can deliver. And this relationship is something that we observe not only in Brazil, but in other countries. And it's important for us to see this is nothing new. The point is that populations are getting older. And when we discuss that we have to do a good reform in terms of the pension plans, we are leaving beside what is not correct, the idea that we do not have to discuss healthcare. People are getting older. And you know, Simone, people used to say that in a couple of years, men, they are going to live more than 100 years. And women, they are not going to die anymore. So we have to be prepared to support this change in terms to add technology according to this new reality and trying to bring new efforts to support this older generation that is going to survive in a long term. By this idea, what we can understand is that our healthcare system still do not perform according to what we can expect. If we compare what is happening in Brazil and even in other countries, we see that we have very few automatization, what means that we have a lot of people working, we have many works that we do twice, 3 times, things that are wasting. So to confront to this new reality of the elderly people, we need much more efficiency and efficacy. And it's very clear. The main reference in terms of quality that we observe all over the world is the Institute of Medicine. I had the opportunity to bring this institute to our country and to start to work with them in our hospital. And according to this institute, 1/3 of healthcare expenditure was waste. And this line, we have many things that you can observe. Unnecessary service, inefficiency, prices that are too high, excess administrative costs, fraud, and misprevention opportunities that may show good examples that if we're gonna have an opportunity to work harder, we can diminish this waste and have much more efficiency to each real that we spend per citizen. One of the causes that created this waste is the model of payment. We still have in our country a lot of fee-for-service. And I cannot accept that providers are not going to be worried about outcomes. And we have to change this reality, trying to migrate from the fee-for-service to other and different and better conditions that can create synergy in terms of quality and amount of money that we are spending. Where we are now, we have a very fragmented care, we have provider-centered care, we have a lot of paper, we have patients as passive participants, we have facility-based visits, in a condition that we have to move to a coordinated care, to a patient center. We have to leave all this paper and have to work much more centered on electronic ways. We have to have our patients much more engaged, deciding what they want to do and deciding what they do not want to do. And we have to look for innovative ways to develop care delivery strategies. And what are these challenges that we are facing, not only in Brazil, but in whole Latin America? Unfortunately, we have approximately 30% of the population of Latin America and the Caribbean that do not have access to healthcare. We are living an epidemiologic transition and chronic and non-communicable diseases. We are discussing a lot of COVID, but people, they are still dying because of heart attack, because of stroke, because of hypertension. And these things are things that are leading the causes of death all over the world. We have to train people because we do not have just to bring technology. We have to have a whole staff that is going to be able to work with this new technology. We know that in the coming 10 years, the world is going to need almost 80 million new people that are going to be prepared and trained to work on healthcare. We have a lot of inequalities in health, many sections of the population that are at higher risks, as health problems are often influenced by social factors. And this is important because even now, people that have low income, they are getting later to hospitals and they are dying. So social protection is something very important to have better outcomes on healthcare. And we still have financing health systems that we have to improve. And we have discussed this mainly according to the models of payment that we have today. And these models of payment, if we want to influence, if we want to change, we have to move from this model of fee-for-service for something that may represent a strong commitment of those that are delivering. They have to deliver in a better condition, in a low cost. We have to find ways to limit cost-sharing mechanisms with patients, because sometimes patients, they think that if they're gonna do more exams, they're gonna be safer. What is not true. We have still very limited prevention efforts and a lot of lack of information that allows continuity of care and systemic management. And now a new challenge, our COVID. I'm discussing a lot here in Brazil, trying to influence, trying to bring efforts in a way to help a situation that is not happening just here, all over the world, and some of specific conditions as isolation. We are discussing how we can organize just a single line, put people in the intensive care units, and this is something that we have to influence. I believe that public policies are things that are not created by those that are in the government. The social and the community has to influence, has to work very hard, that has to discuss and have to participate in creating better health policies. Everything that we're discussing about the coronavirus challenges could be better if we had the vaccine and if we have medicine, but we do not have. So what we can do? We have to work on the transmission. The way how it is designated is by what we say RO. So in the moment that we can diminish this RO, it means that we're gonna have lower levels of transmission. And the second point that we have to work very hard is in our capacity installed. And these two things have been the most important points since the beginning, and people, they have to be working on that since we do not have the vaccines, we do not have the medicine. And what is the current scenario? We have a curve. This curve has an exponential growth. And in the moment that you diminish the transmission, isolating people, you diminish also the exponential transmission. What means that Brazil is trying to do what we try to do all over the world. Here, just for you to recognize that even though our countries, Brazil and United States, we have a lot of cases, we have to consider that those that are dying, this is not something that we can check just according to those that are becoming sick. Since we are not doing tests in everybody, we have to consider those that are dying according to 1 million people. So, and you can observe here that Belgium, this is a nice country, they have rates that are much higher compared to Brazil and compared to United States. And what is the idea? The idea is to flatten the curve in a way that we can accommodate patients that are going to need intensive care unit facilities in a way that can be more rational. São Paulo has created a good plan. I just bring this to give you an idea. And you can see here, I'm sorry that it's presented in Portuguese. We are always considering new cases and opportunities of occupancy that we have inside of the hospitals. And besides that, opportunities and capabilities to do tests in patients that are symptomatic or they have suspicious clinical pictures. So in these areas, you can classify and according to what we can classify, we can decide to continue isolation or to stop isolation. But what is going to change after this pandemic period? First point, we have a very center hospital model, and this is not the best because hospital models, they are very expensive and they are created hospitals to high complexity. So every time that you bring a low complexity patient inside of a hospital, it becomes not safer and it becomes also more expensive. So we are going to make our primary care even stronger than it is. According to the data that we have, 90% of the first visit is able to resolve a problem when you have a model like this, since you coordinate the care. The digital world is something that is not fully integrated to healthcare. That's what I call the healthcare plan for people 4.0. We're going to have to make apps even more important. And even telemedicine, that is something very frequent in the United States, and it was regulated in 1996 United States. In Brazil, it was not regulated. This is something that is going to be established, and people, they are going to adopt this as part of the routine. Even the role of the healthcare professionals. Our modern army are our healthcare professionals. They are going to be more prepared to different challenges and how to deliver in a better condition. We're going to have new models where you're going to be selling healthcare system direct to consumers, not necessarily through the traditional HMOs. And all these things, in the way they can happen, we have to have more flexibility in our regulation. We have to put the research in the right level. We have to involve and to make our patients much more engaged, not only to consume as the consumers, but as part of the decision makers. We have to make our PPPs. I don't know if you guys from United States, you are familiar to this, but we used to have the complexity of the industrial field here in Brazil that was designated just to healthcare. And this was an important program because we have a market, a very huge market, 210 million people that can consume. And today we're not able even to have ventilators, and we do not produce them here. In Brazil, Simone, we have 15 million people that they have diabetics, 25 million people that they have hypertension. And all these people, we cannot be dependent on foreign industries. I'm very liberal, but I think that this is something that we have to take into new consideration. And these are the points that I'm starting. This is the way that I want to start my conversation with you. Thank you very much, John. Thank you very much, Simone.
Thank you very much, Dr. Lottenberg. We do have a couple questions. I wanted to remind everyone that if you have a question, please put it on the question and answer tab. Let me just start off with one question. You already talked about a little bit about this, but certainly Albert Einstein and Mortality are the two leading hospitals in Brazil, at least for adults. What changes in care do you expect to occur after this pandemic passes? And what in particular will change for private hospitals?
John, this is a good question, because probably people, they are going to become afraid of visiting hospitals, mainly because they're going to be in contact with people that can have infections. I cannot talk about Syro-Lebanese. I do not know exactly what they are doing, but in our hospital, we are creating opportunities to spin off patients that are ambulatory and those that are going to be inside of hospitals. It's interesting because even though we have just this terrible scenario, in our hospital, just 2.5% of our professionals, they got COVID. So we have to create protections. Because of this, we have EPI, we have all these instruments that diminish the contact, and I believe that things are going to change. But listen, a hospital cannot consider just a hospital. A hospital has to be a system. A hospital has to have its inside organization and things that you have to do outside of hospitals. In the past, we used to say that the average time that people used to stay inside of the hospitals 10 years ago used to be 5.3 days. Today, 65% of the population that are inside of hospitals, they leave the hospitals before 5 hours. So we have to change this environment. We have to prepare something that is going to be safer, less expensive, and more than that, something that can make the experience of the patient much better. And in terms of experience of the patient, we have to recognize that they are going to be afraid.
Good. We do have quite a few questions already. Maybe you were talking about that. Maybe you can expand a bit on the role of SUS, the emergency rooms network in Brazil, for the disenfranchised populations, and maybe even more, the extension of hospital care to the poor ranks of Brazil.
Well, first, let me try to explain, because SUS is just part of our system. 77% of our population, they use SUS. 24% of our population, they are part of the private system. And it's important because the private system, if it would not exist, all those people, they would be inside of SUS. So this is something that we have to consider every time. When you see the SUS, we have in our country 440,000 beds that are beds to the whole country. 60% of these beds, they are private. And 50% of these private beds, they are used by the SUS system. So the system is not completely separated. They have some kind of surpass. They are superposed, these systems. SUS is an important system. This is the biggest universal system all over the world. We have 46,000 interfaces between SUS and our patients. We have the Programa da Família, Saúde da Família. There is something very important that helps people to be cared inside of their homes. But the point is that it's a big challenge, so it's not so simple. We have to understand that we have not just one Brazil. We have some Brazils inside of one Brazil. Different realities. If you go to Manaus, it's a different condition. If you come to São Paulo, it's a different condition. And even the way that people live, all over the world, we have 30% of the population that they live in conditions of a slum, favelas. And in São Paulo, it's very hard. So all these things, they have to mix together, and you cannot understand or believe that SUS is guilty about this. I would say that SUS is a good answer and a good surprise in terms of efficiency.
This one is my own question, and sort of complimentary, because we see a lot of reports in the United States that I cannot find the numbers and things that what they're saying. I mean, in fact, there's things that border on falsehoods reported about Brazil. There's a bit of hysteria about Brazil's situation right now. Can you give us maybe a snapshot of where we are, how the hospitals are dealing with COVID-19? I know some of it goes unreported, and the testing you already talked about is small, but it's also small in the United States, although increasing. But there's sort of a number of things that just don't add up, and I cannot find numbers anywhere, either at Johns Hopkins or WHO or different places I look for numbers like this, even in the Brazilian numbers. So maybe you can maybe put to rest some of the things that have been touted in the international press.
Well, let me say, what is the main problem? We are not able to make tests as we should do it. And this is something that makes things even harder, because when you have to take some decisions without being sure about the number of patients that they have COVID, even they are asymptomatic, it makes things much harder. Besides that, we have two curves, because when the COVID situation started, it started with the premium curve of the population, those that can afford. And for these people, hospitals, they are not full. They have a rate of occupancy of almost 45 to 50%. So this is not a problem. In the public area, you have to check according to the area of the country. We have some places in São Paulo, we have today 70% of the occupancy being used. We still have place for those that are going to need intensive care unit. But when you compare to what is happening in Manaus, in Belém do Pará, when you go to Recife, and even to Rio de Janeiro, the situation is more difficult. The problem is that I think even though we have general numbers that are not that bad in terms of physical facilities, the point is that they are not proportionally allocated inside of the country.
I think Simone has a question. Simone, let me pass this to you.
Yeah. Claudio, I remember some time ago in Brazil, there was an effort, and I'm not sure, maybe I don't have the correct information, but you can explore and tell us a little bit about that. When you were mentioning about SUS, I remember there was a certain cooperation between the private hospitals and the public needs and the SUS, and they were able to use the surgery rooms, and they were able also to use certain times of the hospital. So there was a kind of a parceria, there was this cooperation that I think improved a lot the lines that you have in SUS for certain surgeries in São Paulo. Is this something that is happening in Brazil? Is there some type of cooperation that still exists? How do you see that now and going forward?
Listen, what you say is what we call organizações sociais de saúde. This is one point. Another point is what we call as mutirões. And in São Paulo, former mayor, today he's our governor, João Doria, who was hosted by the chamber 3 years ago, he created the Corujão. What is the point, Simone? I think it's silly for us starting to build facilities without using the facilities that we have in our private sector, and they are empty. So what is the difference between one system and the other one? They are not different. In terms of social right, both are important. For one, you have less line. For the other one, you have a bigger line. But the point is that why we have to repeat and buy things that are ready to be used. I can go to the example of labs. Labs, you see exams, it's a factory. There is nothing that we have to do. There is with the hands. So you have a factory. If you produce 1,000, 10,000, 100, 1 million, so we can use all these factories to SUS and to the private system. The label is different. When you're gonna you see to do cataract surgery, just to bring something that is related to my to my work. You take almost 15 minutes to do a surgery, and you have a lot of operating rooms that are empty during some periods of time. So what the government was trying to do and what they did, they started to look for private hospitals, to private organizations, and instead of creating models, they started to buy. You know, those that are more leftist, they consider this as a mistake because you are delivering the money of the people to the society. It's silly because for the patient, and we have already observed, and it was a study that was published in the newspapers, that for the patients is not important. They want to have their problem solved. So this is something that is starting to happen. The social organization is something that, in our case, also Albert Hospital has 2 hospitals that are working with us in this model. And recently, because of COVID, all these hospitals of Campania that we're creating, they are creating under partnership between private hospitals and the government. When you are in the United States and you talk about Medicare and Medicaid, the hospitals that they use are the same as those that are used by the HMOs. So we have to bring this model, stop with this kind of political discussion, something that should have been surpassed since the wall of Berlin has been disrupted, and start to do things in a way that can bring satisfaction and resolution to our patients.
And this for sure is bringing efficiency because, as you said, is using surgery rooms and equipment that are not being used. And another
For
question
sure.
that I have for you before I pass back to John, in the terms of education, I know that one of the last initiatives that Albert Einstein had and you had is the university. How do you see also the education coupled with the hospitals, and how do you see this for other hospitals? Because I don't see, of course, in the public sector, you do have hospitals in the universities and all that, but how do you see that move, and do you see a trend that others will follow?
Listen, Simone, we're gonna need a lot of professionals since we're gonna face with different challenges. More than that, technology, it changed so much that we have to implement a continuous program of education. It's impossible for us to understand that the government is going to be able to create programs like this, learning distance systems, things like this. We have to put money. So there was a moment that I decided to create, to bring to our hospital a medical school, because we are going to need 10,000 doctors in the next 5 years to our facilities to work with us. So we have to create these doctors. And more than that, you see, education is important because we have people, they are fantastic in terms of technical skills. But to be a doctor is not sufficient for you to know just technical skills. You need leadership because you change every time. You have to bring new opportunities. You have to take care of human beings. And human beings, not necessarily, they need just medication. The role of the doctor of the past was something much bigger than what I'm doing today. They used to help families. They used to help how to understand the limits of the technology. I see many times that people, they believe technology is going to resolve everything. So doctors, they need a new profile. I think that what we did was something that was going to be important to external purposes, but mainly for internal purposes. And I think that our competitors are going to do the same because they have to create their own capabilities in a way to solve and to face these challenges that healthcare is going to bring.
Great, thank you. You did mention the purview of what you're doing and where healthcare should go is beyond just medication, but we do have a question about the price trends of medicine right now and the availability and how much Brazil depends upon imports for medicine at this point.
And this is a problem because you have a big market, and sometimes people, they come to us and they believe that we are going to pay the same amount of money that you observe all over the world and even the United States. And this is not our reality. Our GDP per capita is much lower. The amount of money that we spend on healthcare is much lower. And we have to find alternatives for this. We still have a high dependence on medications, on machines, things that we have to buy from abroad. 2 or 3 years ago, it was not like this. On December 2017, former President Michel Temer, he canceled that idea of the PPP. I was against this because I think this is an opportunity also to create employment to our people, but we are very high dependent on countries like China, like India, and I think this is very bad. Even today, John, we bought ventilators to Albert Einstein Hospital, ventilators. A good client that pays in a good way, we have a commitment, and suddenly, because of interference of other countries, they just canceled with everything signed and money that was already paid upfront. They gave back the money, but they decided they are not going to send things that we bought. So this is something that we have to change.
Thank you. We do have another question. It has to do with basic sanitation, because that's also something that is fairly important in the center of the discussion, especially on privatization. But the question starts out, fact, Brazil needs basic sanitation and emphasis on preventive health. And then the question is, instead of employing doctors in the public system, why not implement a fee for a service for the providers? A modest fee per service works more efficient or efficaciously than doctors who are paid whether they work or not. And that you had talked a little bit about that in your program. And then he has three questions here. Well, we'll just start with that, and I'll give you, I'll add the other ones later.
Let me tell something, John. It's not true that sanitation was a problem. In some parts of the country, it's true. But if you go to São Paulo, it's not true. Sanitation São Paulo, they did a very interesting and important work. And I was able to learn and to read about it recently. And here, when you talk about employing doctors in the public system, I think this is not good. We should invite them to work in a more liberal way. But what comes to me, and it concerns me, is when you say about the fee for service. One point is when you pay a doctor. Another point is when you pay for a treatment. You cannot pay a treatment according to a fee for service system, because you're going to stimulate, you're going to emphasize the importance of the waste. I'm completely against fee for service.
This is a question, you touched on it also in your presentation. Maybe you can flesh it out a little bit more about testing, because certainly any post-COVID or coming, whatever next steps are, which we're going to start talking about next week, depends upon, most strategies depend upon a lot of testing. Certainly the United States was behind in the testing and now is ramping it up. What is the situation in terms of testing, and how soon do you think there'll be enough of it to allow, I guess, a more rapid opening, or return, a little bit more of a return to normal, nothing fast, but a little faster than being locked down?
Listen, we have two kinds of tests. One of them is the PCR, where you amplify genetic material of the virus, and this is more sensitive and very specific. The other one is where you measure antibodies, and this virus is a terrible virus because he's very low immuno, he has a very low power of immunogenic power. He produces very few antibodies. So in the very beginning, you're not able to detect. So the patient is sick and do not detect even antibodies of the acute phase, the EGM. So what would be the best would be to be able to do both testing in a way to create like a passport that could allow those that have already had the disease to come back to work. But it's something very limited. We haven't had the opportunity to do all these tests, and it could be, in my point of view, a very good contribution if the government could have decided to ask for the private sector to do the tests. We have in the private system, we have almost 47 million people that are part of the system. All these people, they are related to HMOs. Why not giving to HMOs opportunity to do this kind of screening? These people, 47 million, almost 20 million, they are in São Paulo. In São Paulo, you have the highest GDP. In São Paulo, you have the highest number of employment. So if we had conditions to organize at least the situation in São Paulo, probably part of the isolation would not be happening anymore.
So testing asymptomatic people is not yet all that strong, not that viable. So that's one of the most important things for opening up again. So maybe
it's true, because 80%, John, 80% of the population that they have the disease, 80% they are completely asymptomatic.
Yeah.
And these people, they had the disease and could be able to come back to work.
Very good, thank you. Another question is maybe the current state of treatment of those that are already infected or that have the sickness. I know it varies all over the place, but maybe you can address some of the things that that were used for malaria and rheumatoid arthritis, and also maybe some of the things that are developing by a number of international drug companies.
Listen, this is something interesting, because that drug, the chloroquine, that was against malaria and against rheumatic diseases, you can use them off-label, but nothing that can prove completely that it's going to work. And the point is that they want to recommend this to everybody in a way that people, they run to the drugstores and they bought, and those that really need the medication, they could not have it anymore. We have some studies that are being done. We have to be very careful about this, because many times patients, they become better, not because of the medication, but because of the infrastructure of the intensive care units. So we have to control. I understand that we are in a hurry to find conditions to resolve this problem, but this hurry cannot be even stronger than the rigor of the scientific way how to develop conclusions for healthcare. The second point, something that is going to work, is the hyperimmune blood plasma. You have to take blood of patients that they have already had the disease. These patients, they are excluded when they have other kind of diseases at the same time or before. And it has been working very nicely. But it's not so simple to have this kind of material. It's something that we have to produce. And I'm very enthusiastic about this. Recently, something was published about remdesivir. It's another antiviral drug. And this drug has shown its positive effects on reducing the average time of the admission inside of the hospital. But the mortality rate was not decreased. Well, people, they're trying to find things. What I can observe is that we are much faster than we would be in the past, but still very far to have the solution, something that we can say that it's going to work, it's going to be the silver bullet.
Yeah, certainly silver bullet is in the horizon, but some of these are encouraging for sure. We're starting to get to thinking about the post-pandemic situation, and let me just ask a couple things along that. First, do you think that perhaps there are some benefits or blessings in disguise from this pandemic, such as dislodging some of the things that are preventing Brazil from improving its efficiency in healthcare services, perhaps how healthcare companies are regulated, also allowing more innovations, and this gets into a big mess of questions like intellectual property rights and things like that. But just what do you think may come out of this in terms of things that have heretofore not happened in Brazil in terms of providing healthcare?
Listen, we have two agencies that are related to healthcare. The first one is Anvisa, that works mainly on medications, machines, gadgets, and ANS, that regulates mainly health plans. It's clear to me that things, they have to change. I'm very suspicious because I have always have been working for this change for a long time. But we cannot take such a long time to approve a medication. We cannot spend such a long time without having telemedicine regulated. In the United States, and I said in my presentation that in 1996, in your system, we had telemedicine. Even Angola was faster than us. And right now, they decided that we can use telemedicine, but just for the COVID. We have to have more flexibility in terms of the health plans. I was in Spain, John, many, many years ago. In Spain, for low complexity, almost everybody buys a health plan. But to high complexity, what is an exception? They have the public system. I'm just giving an example of something that can be creative. And what happens when you have more flexibility? You bring money to the private sector. And it means that less people are going to need the public system. So all these things, they are going to change. And what is the point about the Congress? The president of the Congress, he has a strong position and he understands and he has the commitment to change this. But as you know, politics every time changes, people, they change. And I'm not so sure that they're gonna be approve all these things, but we are putting pressure. And I think that this moment is going to teach us that we cannot be stopped in these things just observing. We have to change.
We have a couple of questions that are kind of related. One has to do with telemedicine. You think, there's a lot of there were restrictions that were lifted on telemedicine, and also robomedicine, just long distance appointments. What do you see the future of both of these? And you think the telemedicine will go back the way it was, or also the moving into more robotics and those, or even manipulated by doctors, type of non-invasive type things?
Listen, the first platform of telemedicine, I was responsible for that in Albert Einstein in 2012. I was in Israel and I could observe that the emergency rooms in a big hospital, they did not have almost children. And they say, listen, these children, they call the doctors by telemedicine. If they do not resolve, they come to our hospitals. What happened since we started with this process of telemedicine? Just 1/3 of the patients, they decided to continue to come to hospitals. And from this 1/3, when they come, 1/3 of them, they have to be admitted in our hospitals. What means that when you look for hospital, in this case, you're gonna be looking for somebody who really needs. This is going to change completely. And this is the modern life. We have in our country, John, today, 85% of the people that are living in almost 450 cities. What means that these cities, they have 5G, 4G. So all this information, you're gonna be able to deliver instantly in the same moment. All the solutions that you can bring, you can resolve in a country like ours. It's going to be impossible for us to have a system where you're gonna have somebody who is an expert that can live in a very small city, but you can have a second opinion. And people, they're gonna have it very clear now, and the population is gonna demand, not ask for this kind of solution. And we have to be creative, and we have to innovate, we have to be courageous, and we have to change something that is very, very well bad done in our country.
Claudio, I have a question for you. Since I agree with you that the future is more related to telemedicine, that we get much more efficient, and you really take to the hospital patients that need to be in the hospital, and you also decentralize from the hospital with the primary care. Why do you see, on the other hand, certain hospitals in Brazil buying, consolidating hospitals? It seems for me that is against the trend, and it's, this consolidation and all these acquisitions that other hospitals are doing in Brazil go in a different direction because they increase the number of beds, but not necessarily the efficiency. do you think what is the logic behind if there is any and against or in favor? How do you see the future for that?
I think that they have their strategy according to the model of payment that we still have. So in the moment that you're going to stop with the fee for service, these things are going to change. So great part of the money that we are doing, and I show you right before, is coming from wasting, and we have to stop. This is the reason that I'm trying to defend new models. You have to come with outcomes, you have to have commitment according to what you are able to deliver. You cannot just admit people. You have to take care of hospitals according to the level of complexity, not according to what they are able to sell as they work today in the fee-for-service. So if you want to continue wasting, it's going to be like this. I think these things are going to change completely from now on. Things are not going to continue like this, Simone, believe me.
Hopefully.
We have a question about sort of social distancing. I know this isn't quite exactly what, but you know, in terms of expecting a directive by the federal government, maybe you can, you know, Brazil is a federative republic the way the United States is, and this is really up to the governors and mayors, but maybe you can talk just a little bit about that, because if you're reading the United States newspapers, there's no restrictions whatsoever, even though if you look at any index, the Oxford University one, or a couple of the Financial Times one, Brazil is just as closed as the United States. So maybe you could clear that up for a little bit for us.
Listen, I told you in the very beginning that we are in a reality that we are using tools that have been used in the last 100 years ago. We are keep distancing. We are asking people to wash their hands. Maybe what is new is the alcohol gel. Besides that, everything is the same and old remedies. What is the point? You see, I understand that we would have in Brazil to have something completely different. Our governance is very bad because the role of the systems happens, as you said, in the cities. Even the governors, they have some role, but they have to coordinate something that has to be decided by the mayors. What is the point? We have a lack of alignment of a speech considering the president and the governors. The president, he has concerns about the economy. And it's true, because if the economy is not going to run, we're going to have huge problems. Even more people are going to die because of the consequences of the economy than those that are going to die because of COVID. But at the same time, we cannot diminish the importance of COVID. People are dying. So if the president, he starts to walk without masks, going close to the people, he is a national symbolic member. So his example is something that brings all the people to another reality. So I understand that the problem of COVID is something that we have to resolve according to technical opportunities and not according to political initiatives. And unfortunately, what I see is that this important problem has become a political problem and not a technical problem.
Since you brought it up, and this will be sort of some of the things we're going to be dealing in our next series, so next steps, what are you thinking about the scenarios for the economy versus the pandemic over the next year or so?
John, I could not understand. Could you please repeat this?
Yeah, you had brought up the question of whether people can go to work or not. The question of the economy versus fighting the pandemic. You brought that up. What do you have in mind in terms of scenarios for the next 12 months or so, or next 18 months, in terms of how we might see this play out?
Well, first, I think that we are almost in the peak of the curve. So I understand that very soon the number of new cases are going to diminish. If you're going to be in an area where you're going to have a sufficient number of beds to give support to that population, you can decide what are going to be the more vulnerable situations where you have to bring people to work, those that are risks, group of risks, and things like that. The situation in the country is going to be very bad. We understand that we are going to have, I would say not depression, but we are not going to increase. The point is that we have an expectation at the beginning of the year that the country was going to increase 2%, 2.5% in terms of GDP. Optimistically, people, they say that they're going to be -2. So it's not going to be very simple. We're going to observe depression. I think that healthcare maybe can be something that is going to add value, but all the areas, we're going to have high and difficult problems. The unemployment rate is going to increase. And when I say increase, it's not just 1% digit, but millions of people that are going to stay without employment. We have problems with people that not only unemployed, but those that have never had formal linkage with the formal relationship in terms of employment. So it's going to be a very hard moment for us in terms of economy.
You talked about the protocols in São Paulo, and that's one you'll be most, I'm going to ask you a question later about the future, but perhaps you can elaborate a little bit more about how how effective those protocols have been, and especially in, helping, the informal sector, people in favelas, not only on the medical side, but also, the effectiveness of social distancing. And certainly that is a huge challenge for all levels of government in Brazil and for the Brazilian society as a whole.
John, you brought something important, because you see, one of the points that we discussed about social distancing is you recommend, since you are sick, you go inside of your room. I would ask you, how many people they have a house with different rooms in our country? So it's not our reality. Today they were discussing how to create a common and single line to bring people inside of the intensive care units. Listen, we have hotels that are closed in the city of São Paulo. These hotels are going to be much cheaper. If you put people that are in the risk, elderly people, people with diabetics, oncological patients, and put them to live inside of these hotels for a while, probably you're going to isolate people, and they're not going to need these intensive care units in the future. Because this is a social problem, as you said. Between 2011 and 2017, we found a study that was able to show that in countries with low income, that there is a difference rate of mortality when you compare poor people with rich people. In 2008, when United States, we have the subprime crisis that has affected many economies, the mortality rate didn't increase. You have more suicidios, you have more mental diseases, but the mortality rate didn't increase. These two papers, they are a real proof that social protection is very, very important when you consider how to work on healthcare. So I want to insist on that we have to work very hard, not only to increase healthcare facilities, but mainly to improve our social protection.
Simone, did you have another question? I still have a couple more, but I wondered if you had another one that you wanted to ask.
I think that when you talk about the social welfare that we need to create in the country, the problem is much bigger and I think much deeper, and unfortunately it take years. And I agree with you that that is relevant. So again, I think this dichotomy that we are discussing here in US and in Brazil, in the whole world, about which one is more important, it's not a question of which one is more important, if it's healthcare or the economy, but I agree that in Brazil specifically, the consequences will be very hard. If you have to, now it's a question like, let's say if you are the health minister, or if you have a situation that you have to take actions, what would be your 2-3 actions that you take now, Claudio, to make sure that this situation is really under control?
Listen, we cannot consider a country like ours with such a big disparity in the way people are checking and taking decisions. We have different realities in different parts of the country. If I would be working as a minister, I would be visiting the great centers of the country in a way to check personally if we have facilities, what are the conditions, what are the real numbers that we need, in a way to support patients that are going to need intensive care units. More than that, I would try to create a good momentum in terms of relationship, because politicians, they were able to destroy the relationship between different levels of the government. What means that for the economy, mainly for the economy, and for the moment that we have to give money and to forget the liberal life and to be a little bit of Keynes in this condition, this money comes from the central government. So if you're not able to create a good dialogue, I would establish good bridges between the central government and the governors, something that has to happen. The third point, Simone, I would ask for the private sector. And you see, I told you that we have in Brazil 50 million that are employers. So there is no reason for the private sector not to make tests for these people. It's something that you can buy, you bring, you do, you check. All this information can be very useful. More than that, we can create clinical data just working with mobile phones. I was able to discuss with some people from Israel. You can create just with simple questions. You send us SMS, you do not need an iPhone, a simple phone with SMS. How old are you? You are older than 60 or lower than 60? Number one, number two. Do you have diabetes? 1 or 2? Just with this information, creating what we call as hot maps, you could mobilize and find where the people are located. So some small points that could be happening already if we are not wasting our times to discuss who is pro-chloroquine, who is pro-isolation. It's like a caucus, you see, to decide who is going to be the best candidate. So this is the point. And this is one of the reasons that maybe if I had the chance to be the minister, I would not accept. Because we need serious people that want to work with measurement. We need people that need to work with indicators. We need people that want to dialogue independently of disagreement, that they naturally exist in everything. Do you agree with everything that your boss says? Do you agree with everything that your partners, they say? But you try to align. This is the role of a leader like you.
Thank you. Claudio, just another point that you mentioned was interesting, and I'm sure you heard from Cuomo here in New York. You said that you had bought ventilators and paid and everything was set up and they didn't deliver. They gave the money back, but they didn't. Here there was a big criticism that the states were buying directly and the states were bidding up. So whoever pays more gets the ventilators instead of having a coordination from the federal government. Do you think that in Brazil, the national entities that are responsible for that, or maybe here in the US as well, do you think this kind of centralized approach, at least for the ventilators and key things, would help to avoid this dispute between private, public, and between states?
Listen, this is something that you raise and you're right. This is something that the central government could be doing. It would be much more efficient because sometimes you see those that they say that they have to buy, sometimes for that specific moment, they're not going to be useful. So this is something that has to happen. And it's important because you brought me some points that was not able to discuss because it came to me some questions regarding regulation. Regulation is a problem. The Congress to approve is another problem. But we are not discussing the role of the justice. The judicialization in Brazil is a problem. People, they are bringing things to be decided by judges that do not have knowledge about healthcare, and they decide things according to some emotional interfaces that they're not necessarily the best decisions. So you have a judge that says, listen, in my city, we just have 20 ventilators. I'm gonna create a mechanism that these ventilators that are going to be delivered to another city, they're gonna stay here. But he's not worried. He doesn't know. Maybe the population of that community is a young population. Maybe the population of that community, they do not have risk factors. Maybe that intensive care unit is not fully occupied. So judicialization is a problem. Justice is creating a mess on healthcare, and now they are worse.
We have similar things in the United States, especially around ventilators. Just it's not quite in the judge's hands, but procurement is very unwieldy here to get ventilators between states even, and also trade. And we've had a stance of governments that's highly protectionist or more protectionist than it was, and that's kept a lot of imports from happening on the equipment front and on other things like gel, et cetera. We do have a rather pointed question here in terms of getting extension services into the favelas. Have private hospitals and public hospitals constructed isolation centers, maybe tents or something like that in favelas or the harder to reach places right now? Has that happened?
John, it cut a lot. I was not able to understand you. Do you mind to repeat, or even in Portuguese if you prefer?
The question is have private or public healthcare providers, doesn't even necessarily be a hospital, have there been any construction of isolation centers like tents or something like that in the favelas or in the harder to reach places?
Yes, they are trying to do this. The point is that it's not organized as it should be. The favela situation in the country is something very serious. We have a lot of people that are living there. So it's not something that can be resolved through a non-profit organization. You have to have somebody who is able to coordinate all these things. And the legitimacy of this coordination is made by the government. And what is the point? The point is that the government is not working according to a common language that can align expectations and bring people. What we could observe is that the private companies, they want to help, they want to put money, but they do not exactly how to do it. So lack of coordination that should be created by governments.
Claudio, there was an article in New York Times this week or CNBC I discussed with John that the hospitals here are saying that they are losing millions of dollars per day due to the pandemic because of the protection gear that they need to provide, things they need to buy. And then there is the position, I mean, of the seguros, no, the insurance, the health insurance companies, how much they're gonna pay for that, and if it's enough, not enough, and if you have federal or state funding. So how do you see this in Brazil in terms of what the insurance is covering, not covering? It's more dependent on public sector. And if you see issues in insurance companies, if this pressure of the laws on the hospitals will also affect the insurance companies themselves?
I see a very bad scenario for hospitals because the occupancy is mainly due coronavirus, what means that all the elective procedures, they are not happening. And the hospital without high complexity is going to be a problem. It's not going to survive. We are starting to discuss with the HMOs, because HMOs without hospitals, they also cannot survive. They need a full product to sell for their clients. They are very comprehensive. They are trying to anticipate some of the money. But once again, if we were not in a system the way we are, fee for service, if we have a capitation, for instance, probably part of these problems, they were not happening. But we have to redesign, because all these parts of a chain, they are important in a way to have a system. So we have a problem today in Brazil. As I told you, I can observe that the budgets are not going to happen for sure, but the point is not the budget. You're gonna, I don't know exactly how to say, vai comer muito caixa, Simone. How to say in English?
Oh, it's gonna eat up your liquidity.
Yes, exactly.
Yeah.
And it's a problem. It's a problem.
Okay, thank you.
Very good. Well, we've run out of questions. I'm sure it was out of some exhaustion, I think, rather than not. And certainly this was a great presentation. Thank you very much, Claudio and Dr. Lottenberg. And I want to thank all that got on and are still on this webinar for joining. We are going to start out next week with a new series. What the next steps, we're going to start with first steps, and some of the things we're going to talk about, Dr. Lottenberg talked about today, just how quickly you open. We're going to compare the steps taken in New York State, New York City, to those taken in São Paulo, and that will happen next week. But in the meantime, thank you very much, Simone, for helping arrange this. And thank you so much, Dr. Lottenberg, for your presence. It was really excellent. And
that's my pleasure. Thank you, John. Thank you, Simone.
Thank you, Claudio. Thank you.
And stay healthy.
Bye-bye.